Hi.
Hi, I'll just check. I'll just one second. I'll just share.
Yeah, share and see.
Host isn't allowing sharing for this.
Everyone, I think we've already seen that the attendance is good, and we're looking forward to having our seventh Pulmo-Radio Crosstalk today. Definitely, the last six, I think we've all gone back learning a lot, helping in diagnosing, helping in managing quite complex cases. And that's why, after a lot of popular requests to change the timing so that many more people can benefit from this, here we are, first Wednesday evening, 9 p.m. I think Sir and Neil ma'am have not joined, but I'd like to thank IP Mumbai and NRC for giving us this opportunity, and Hindu Khosla ma'am, Hiren Panwala sir, Sonal ma'am for being here and supporting this. And the brainchild was yours. So welcome all of you. I'd like to welcome today's speaker, Dr. Vishal Samaga. He's second year pediatric pulmonology fellow from Vijayawada Hospital for Children, Mumbai, and guided by his mentor, Dr. Parma Chandni sir. He's assistant professor and head of Department of Pediatric Pulmonology at Wadia Hospital. I request Indu Khosla ma'am to please say a few words and kickstart the session today.
Yeah. So without much ado, I welcome everyone to this Pulmonary Radio Crosstalk. Or it has been a huge learning curve thanks to the presenters as well as our radiologists. The format of this talk would be in such a way that we would have Dr. Vishal present the case, and we will discuss the clinical aspects of it as we go through, and like a normal case presentation that we discuss. But our focus is also going to be more on the clinical radiological correlation. So when we come to the radiology, we will have Dr. Sonal share the DICOM images, and we will take her opinion. We will express our doubts, ask her some more doubts if we have, and that's how we will get enriched by understanding CT images or radiology much better. And at the end of it, I would request Vishal to summarize the case with some inputs on that particular diagnosis that we come to, and if you have some more inputs on the theory of it, so that we go home rich not only with the radiology aspect but also with the theory of the topic that the child had, or the diagnosis that the child had. And we will also have Dr. Parmat concluded as a mentor with his comments towards the end. Of course, he's welcome to give comments as we discuss the case throughout. Yeah. Over to you, Vishal. You can share your screen and we can begin.
Thank you. Is it visible?
Yes, visible.
Okay. Good evening. I'm Dr. Vishal. I'm a postdoctoral fellow in pediatric pulmonology from Vijayawada Hospital for Children, Mumbai. And I'm guided by my mentor, Dr. Parma Chandni sir. He's an additional professor and the head of our Department of Pediatric Pulmonology at Wadia Hospital for Children. So today's case is a very mysterious one where we have called it the puzzle of recurrence. And let's try to solve this puzzle as we go ahead with the case. So coming to firstly the history, we are going to see the case of a 9-year, 2-month-old male child who currently presented with fever, cough, and cold since the past 5 days. Fever was documented to be up to 103 degrees Fahrenheit, which was associated with chills and relieved on taking paracetamol. And the child was active during the interfebrile period. Cough was a chronic wet cough which was there for a long period of time, that is up to 3 years. But the child and the parent both mentioned that it did not trouble the child during his daily activities. So currently, the child presented with acute worsening, and the cough, which was noted, was productive in nature with some mucoid expectoration. There was no history which was suggestive of any previous foreign body ingestion. There was no diurnal or postural variation of cough. There was no history of any hemoptysis. There was no other significant history of any fever with rash, any history of otitis media, and there was no significant neonatal history. The child was a term child, male, born by normal vaginal delivery as per date. He was then immunized as per the national immunization schedule, and then he was developmentally normal going to school, studying well. But there was a very significant family history where there was history of pulmonary TB in the father, who was diagnosed with MDR TB, and the father was the parents, the mother mentioned that the father was non-compliant with medication, and he had expired during the COVID pandemic during 2020 with the same problem.
I just want to interrupt you here. In the history, the first 5 years of life child was this is a 9-year-old boy, right?
Yes,
And
ma'am.
he got cough since the age of 6 years.
Yes, ma'am.
So before that, he had no history of any diarrhea, any failure to thrive, any records that you have
No,
of.
no failure to thrive. There was no history of any failure to thrive. There was no history of any complaints of cough as such by the child during the first 4 to 5 years of life. But there was one history of, like I will come to, and one history of admission in the past, which I will be mentioning at around 6 years of age, ma'am. So
Okay.
prior to that, there's no such significant history suggestive of something going on for the first 5 to 6 years.
And no failure to thrive.
No failure to thrive.
Any allergies, asthma in the family, any child with wet.
No, there was no history of any allergy or asthma in the family. The only relevant history was that the father had TB.
Okay.
And
And
was
no
diagnosed
occupational exposure to anything.
No, ma'am. The child, there's no history of cough being triggered or by any exposure to anything as such.
Hmm.
But the only significant thing is the family history and one past history, which I will be coming to.
Yeah, so this history very classically tells you that something went wrong 3 years back, and now you're giving me history of Cox contact in the father. So before
Yes.
that, the child was left. Okay, please go ahead.
So, past history in June 2022, during this admission, while we inquired about the past history, he mentioned that the child was previously admitted with similar complaints that is, child had fever, cough for 5 to 6 days, and had some increased respiratory activity for which he was admitted in wards. And his evaluation for the same complaints was as follows. So initially, he was admitted with a history of, fever and cough. His chest X-ray is a slightly overexposed film, but his chest X-ray showed some increased markings on bilaterally, but the X-ray the quality of the X-ray was slightly overexposed. So because at this point of time, 2022, a child had 5 to 6, it was just a short history, but on probing and asking, he did have on and off cough. So that further, we did further testing, which showed we got a CT test
Go
done.
back to the X-ray, Vishal. There's lots to discuss on this X-ray.
Yes.
Yeah.
Yeah, can you describe the X-ray?
Ma'am, the X-ray is slightly overexposed film. It is slightly rotated to the right, but other than the quality of the X-ray, the cardiac shadow looks normal. The lung parenchyma, because it is slightly overexposed, looks slightly hyperinflated. But other than that, there's some increased heterogeneous markings bilaterally, mainly in the right lower zone.
Yeah.
Yeah.
I think even left lower zone is
Left
showing
lower zone as well.
Yeah.
some amount of bronchial
Retro,
thickening.
yeah, retrocardiac.
Yeah. Would you like to comment on it? Yeah.
Yeah, so you know what I have outlined here, you can see that there are these end-on shadows,
Yeah.
which seem to be sort of these dilated bronchi or these dilated airways with a little bit of wall thickening. If you can see, they're actually kind of seen in both lungs.
Yes.
And there are these patchy shadows or these patchy opacities in the, yeah, let me just erase this. Yeah, so you can see that these patchy opacities in the retrocardiac region, which correspond to the medial and posterior part of the lower lobe. So all these are abnormal, and they do correspond with the fact that he has fever and cough. So they do suggest infection and also possibility of bronchiectatic changes and some sort of bronchiolitis, because there is some prominence of the, almost you can see the bronchial walls which are thickened in the end-on view.
You can also see an esophagus. Is
Yeah,
this
yeah.
correctly?
Just
Yeah.
about
Or
to.
it's hyperdilated. You can see that.
Yeah, so
Yeah,
I was about to mention that
mention this.
Yes.
you can
Yeah.
see that left paratracheal region, no, that this area where I'm going to highlight, that is showing some abnormal gas shadow. Usually we don't see
Yes.
any
This,
gas
yeah.
shadow in that paratracheal region. So when you see this kind of abnormal gas shadow, either it has to be dilated esophagus with filled with gas, or it can be some sort of pneumomediastinum or airfill collection in the mediastinum. So these are the usual DD for that.
Mm.
And if you see carefully in the mediastinum, you can see this kind of here also there is one tubular line going down both sides. So this also might be like
Bronchic.
uh, a airfill or dilated esophagus that we are seeing. You can see this line.
Oh, okay.
We'll see that thing on the CT if it is corresponding. But this is definitely the upper part, which is showing this gas-filled tubular opacity. That is definitely this is definitely abnormal.
Hiren, is the intervertebral distance space, is that
Yeah.
okay here, or is it just the position of the child? If I
That
think
can be sometimes due to position and in the
and
mid-thoracic vertebra
rotation.
we might not be able to see the intervertebral disc space.
yeah, because of the history of Cox contact, I was just like seeing more things than I should see. That's why I was
Mm-hmm.
okay.
Yeah.
Yeah,
Go
so
ahead,
I
boss.
Okay, so main thing which initially was thought of was that because there's slightly, especially perihilar right side, especially left side also, there was some increased opacity. Chronic. I mean, further evaluation with the CT was considered, and hence a CT chest was done at the same sitting, and sorry, in the same admission. 1 second. Yeah.
yeah,
So
so
this is the
if
only
this
CT which the images were not available. The DICOM images weren't available, but the images provided by the parent was a printed CT report. So we only have the lung window.
this is actually showing very similar findings to our current CT,
Yes.
but still I will just describe it. So these are the axial lung window images where you can see that in the center, you can see this dilated air-filled tubular structure, which is the trachea. But right next to it on the right side, so right next to it on the right side, there is another air-filled tubular structure as well. So this is what you call like the double lumen or the double tube sign. And that suggests that this esophagus is abnormally dilated because usually the esophagus is collapsed and you don't see it. You just see a very small air lucent bubble with the collapsed wall. But here the esophagus is clearly distended with air, which is abnormal. And in fact, the lumen is larger than that of the trachea next to it. So these are abnormal features. So then you must track this esophagus down and see what is happening. Is it like some gastric herniation into the mediastinum, or is there some other abnormality like an esophageal atresia? Of course, this child is 3 years old, so we don't expect that. But if you continue that esophagus down here, and here you can see in this image, clearly visible, is that the esophagus is actually forming a fistulous connection with the left main stem bronchus.
Yes.
Okay, and after that, the esophageal luminous collapsed. So that is why the esophagus is dilated because of that air passing by. And as we know, air always rises up. So the upper part of the esophagus is dilated with the air. And as we come to the lung windows, we saw in the X-ray, both the lungs are slightly hyperinflated because you can see that they are far more black in layman's terms, and the bronchovascular markings or all the vessels are sparsely seen, or they are very much separated from each other. And as we come further down in the left lobe, you can see there are these bronchiectatic changes and lot of peribronchial nodules seen in clusters. So that is suggestive of the fact that there is an active bronchiolitis. Even in the right upper lobe, right lower lobe, there are airspace nodules, and that is suggestive of active infection. You can also see some amount of collapse consolidation in the apical segment of the left lower lobe. So that also suggests that there is some chronic infection and like an acute on chronic infection that is going on. And now that we have seen this fistulous communication, you know that that is possibly the etiology where he is aspirating and he is getting this recurrent infection.
Thank you, Sonal. Just for the sake of discussion, I think even a TO fistula will have a dilated esophagus. Will a crying child not have a dilated esophagus? And how do we differentiate that? Just for the sake of discussion, I'm asking.
So, ma'am, firstly, in most of the younger children, we give them sedation while they're doing the CT, so they are not crying. If they are crying, there will be a lot of movement artifact, which is not there on the CT. So he is definitely not a crying child. Secondly, even if they cry, the esophagus does distend, but it never distends more than the trachea, because in general, the esophagus lumen is always collapsed. And even if they cry, they will ingest a little amount of air. It will not be more than the inhaled air within the trachea. So chances are that the esophageal lumen is never going to outdo the tracheal lumen next to it. So when you see the esophagus larger, that is definitely like an ominous sign that there is something going on. There is either a fistula or a perforation or a gastric herniation or something like which is causing so much air within the esophagus.
Thank you so much. Go ahead.
Arnab,
One comment
wanted to
here.
add some.
You said this about this fistulous communication, what you pointed out here. So the esophagus is behind the trachea, right? And you are showing a communication anteriorly.
Yes.
So where is the communication?
So I'll, in the next CT where we have the DICOM images, I'll show it to you. On the sagittal, you can see the
That is the
tract.
recent CT. This is a old CT. This is in 2022.
Correct. But even here, if you see, you can see this, the esophagus is beaking anteriorly on this image. And then you can see a small air pocket. So I honestly, if you would have shown me the CT without showing me the new CT, I would have also questioned it. But when I'll show you the new CT, it's very clearly seen. So this particular dot here is opening directly into the left mainstem bronchus.
Ma'am, can this not be just a silly thing that left?
So the new CT is giving you a clue, and you feel that the old CT could not have been picked up this fistulous communication. That is what you're trying to tell.
No, I'm not saying that. So the thing is that these are images, right? Most likely these images are 3 mm or 5 mm apart. The CT which we have now, we have the thin sections which are all 1 mm sections. So you can clearly see the track going from the esophagus into
The
the
recent
bronchus.
one, right? The
The
previous
recent one. But
the
even
previous one.
here, the very fact that the esophagus is so dilated and then it gets collapsed after the level of this fistula, chances are that there was a fistula even over here.
I just want to add few comments. Like when you see this kind of extra pocket of air, which Dr. Sonal mentioned, which was adjacent to the left main bronchus, and when you see this kind of esophageal dilatation, when you see the bronchiolitis, which is showing peribronchovascular spread of the some abnormality, which can represent aspiration, we could have ruled out or made diagnosis of this kind of abnormal communication with the bronchus and esophagus at that time only, because there are a lot of clues in this CT scan as well, that you are seeing dilated esophagus, you are seeing some extra pocket of air, which is in relation to the left main bronchus. You have got features of bronchiolitis and features that might suggest the aspiration, which is also towards the left side. So these are the soft clues that there might be abnormal communication between the airway and the esophagus.
Dr.
As
Hiren,
Dr.
would you get biased because of the recent CT?
No, but see, I would have definitely questioned to the clinician that why the esophagus
Because
is
you're
dilated.
having a clear view of a recent CT, you would probably
No, boss.
retrospectively.
When
Looking
we are
at the
seeing this extra pocket of air,
esophagus.
which is
See, just
dilated
want to
esophagus.
again highlight this here. You can see here the esophagus is clearly beaking towards the trachea.
Yeah,
And then
yeah.
over here in this section, you can see, as Dr. Hiren mentioned, that extra pocket of air where my pointer is. And you can see the narrowing or the beaking of even the bronchus over there. If you compare it to the right bronchus, you can see that there is an abnormal air fluid level even in the left bronchus. And you can see that beaking of that air pocket towards it. And after that, the esophageal lumen is collapsed. So these are very, very, sort of clear signs, or they are very telltale signs that there is something going on over here, which is most likely a fistulous communication.
True.
Great.
Ma'am, I just wanted to ask, since this is Vishal, ma'am, the bronchus branching out to the right and left main bronchus, given that the esophagus, I understood the point that it is dilated, but given the fact that it is just at the branching point, if there are no serial images at this point of time, could it not be, I mean, can it still be the bronchus is what my question is. I know you can see a small tract which is kind of connecting the two dots. But if you're seeing the CT for the first time, and could it still be a bronchus is my thing. Whether at the point of branching, the
So the bronchus has not yet branched
at the
out
left,
into the, see, this is the carina, right? This is
yes,
the
yes,
carina. So
yes,
the
ma'am.
bronchus has not yet branched out. You can clearly see the upper lobe, the first branch is at this level. So what is this doing? Unless you are saying that there's a supernumerary bronchus or a pig bronchus over there, then you should be able to follow this particular gas shadow. You should be able to follow it into the lung. It is almost like a diverticular outpouching, which is only containing air, right? It is blind ending. You can't see it on the cut below. Neither can you see it on the cut above. But on the cut above, you can definitely see that this part of the esophagus is beaking up superiorly. So it has to be coming from there, right? I mean,
Okay,
what else would be your thoughts as to what is this focus of air?
okay, okay, ma'am. Okay, ma'am.
Guys, go ahead, go ahead. We have few more slides.
Yeah, so as you can see here now in the left lung, there is like a shower of these peribronchial nodules everywhere. And you can see these bronchiectatic changes in the lower lobe. You can see very severe peribronchial thickening. So you can see the bronchial walls are, the thickness is more than the thickness of the bronchial lumen. So that's very severe peribronchiolitis. And you can clearly see that there is a discrepancy between the nodules in the right lung and the left lung. So in the right upper and middle, upper and lower lobes, also on the top sections, we had seen some nodules, but here you can see the left lung is very severely affected. So it is very much like a pan bronchiolitis with peribronchial nodules, and these typical clusters of nodules in the peribronchial regions, you know that this is like a peribronchial infection because of the underlying bronchiolitis.
So the couple of things are not matching here, Dr. Sonal, Dr. Hiren. The clinical history, the child being normal till 5 years, started having cough, and now this fistulous communication, and the amount of lung involvement with this fistulous communication. Do you feel a child who is having a fistula should have this bad CT or X-ray, or it should be more bad than this? And what? How do we explain the clinical scenario of a child being normal till 5 years and developing this?
So, firstly, this is not a tracheoesophageal fistula, right? This is a bronchoesophageal fistula. So, the tracheoesophageal fistulas are the ones that are usually congenital, and bronchoesophageal fistulas are usually acquired. So, in this child, that is what, when we saw the CT, also that was our question. Did he have like some fulminant TB or something that gave him cacheating lymph nodes or some sort of cacheating lymphadenopathy, which has the caseation always tends to rupture outside, and
Yes.
that has caused this fistulous communication? Or was there some ulcerative process happening in the esophagus which has formed this fistula? Or what exactly happened at this 6 years of age when he got this infection for which he was admitted?
So I have some thoughts here. I there are two, three things which come to my mind. One is this is the time during COVID when the father had MDR TB, when patients were at home, because we had a similar case like this of TB, which was a slow smoldering TB which went on for very long. The contact is close, the medicines are not proper, and these are kids who may mount some immune response, and therefore it's a slow smoldering TB which causes more lung damage. So this child could even have had esophageal TB for all you know, which could have perforated, and from there it has formed a fistulous tract from the esophagus to the bronchus. So I feel it is the fact that a close contact in a time during COVID, where even nutrition may have been a problem, treatment may have been a problem, has possibly resulted in, and this is obviously an acquired thing and not a congenital thing.
I'm having different thought. It may be congenital also because there are some case series of congenital bronchoesophageal fistula as well. So if we don't have concrete evidence of prior TB or some other infection, this could still be congenital in origin. And in that case series of bronchoesophageal fistula, they have mentioned that sometimes these cases may present in later, sometimes in adulthood also, which can be missed before. Maybe the aspiration is occurring silently, but the child is somehow not producing that much of severity of symptoms. For the lung finding, what we are seeing here, that we are definitely seeing that there are some chronic infection or chronic aspiration related changes, which Dr. Sonal mentioned that bronchiectasis is there. And if you carefully see at each section, the lung volume on the left side appears smaller as compared to the right side, even on X-ray as well as on CT. So it definitely says that there is some sort of chronic volume loss and chronic damage to the lung. And maybe the aspiration was very minimal or it was repeated, but was not severe enough to produce that clinical symptoms. But if we don't have that concrete evidence of any prior infection, this could still be a congenital bronchoesophageal
In
fistula.
this CT, do you see significant necrotic lymph nodes?
We are not seeing that.
So this CT is, we are seeing the lung window, but what I am seeing here also is that the spleen is still enlarged from whatever cuts we can see. So this might also still be an active TB. We can't rule that out. Like he's still having TB, which has not been treated because he's never got AKT. So this extensive peribronchial clusters with that typical tree in bud branching pattern, he could still be having TB. And if we show the new CT, there are a lot of lymph nodes which are heterogeneously enhancing in the new CT. So maybe, as ma'am said, this slow smoldering TB, which has not yet got treated and it has eroded into the between the esophagus and the trachea and
Generally,
caused all
like
these
in patient
problems.
with TB, whatever, like Dr. Indu has shown that case of fistula, but in that we see some sort of soft tissue thickening, soft tissue scarring along the bronchi, uh, in the mediastinum as well as in the lung. So that kind of finding, are we seeing in the mediastinum any abnormal soft tissue thickening along the bronchus? Like
Dr.
then we
Baba,
can raise.
have you done a bronchoscopy on him and looked for evidence of TB?
Yeah, so we are coming to that. So this dilated esophagus, you feel is congenital or is because of the tuberculosis?
It's because
No,
of
usually tuberculosis doesn't lead to dilated esophagus.
That's
fistula.
what.
So it is
Fistula.
it is
So there are a
basically
couple
due
of
to.
things which are not straightforward here, right?
No, it's basically due to fistulous communication between the airway and the esophagus.
That is
Uh,
understood.
yeah,
So
yeah.
either it is acquired or a congenital.
I mean, that will be, we have to rule out all the
Fine,
acquired
we'll come
causes
to
and
that.
then we
Come.
can label it as a
We have
congenital thing.
20 minutes, 30 minutes. Go ahead.
Yeah, so whatever I have read about fistulas which can come from esophagus to the lung, it's seen very commonly even in adults following a malignancy or even a tuberculosis infection, where it can cause such a kind of a fistulous communication. So it could be congenital or acquired, but when you have a history of contact with TB, I would first like to rule it out because it is presenting later, though congenital can also present late. It depends on how much is the connection, how much is the aspiration, which will decide when it will present, I think.
I just have one question. If it was congenital TB, he would have been silent for 5-6 years.
Congenital TB, need congenital communications.
Fistula.
Yeah, that can, there are some case series that we
Yeah,
have seen
So
that
even
recurrent fistula
that's what
in adult
even
age
whatever it
groups.
is congenital, would it have been silent for 5 years?
No, so that is what I truly don't believe, that a congenital fistula would have been silent for 5 years. I truly feel this fistula is acquired at some point because of his TB or whatever infection you want to hypothesize. I don't, and also the nature of this fistula, it's like a very windy, irregular sort of tract. When you see the congenital tracts, right, they are because of the epithelium not being complete. So they are very straight tracts. You see tracheoesophageal fistulas, they are straight tracts. This is a very windy tract with irregular margins. So that very much shows like as if there was some infection which has eroded it and caused it.
Even a necrotizing bad pneumonia can sometimes erode into this and can cause it. So any bad infection may not be even necessarily TB if you don't get evidence of TB here.
I just give the input that CT was reported as, like you mentioned, ma'am, but they also mentioned that there could be a necrotic, there was a left hilar necrotic node, but this, I've only got the lung film, so lung
Yeah.
window.
They have given contrast. You can see the contrast in the background, but the mediastinal window is not there. So maybe there is a lymph node there.
Let's go ahead, Vishal.
Yeah.
So, considering the family history of MDR TB and given the X-ray and CT findings, we whole TB workup was done. Gastric lavage gastric lavage for both AFB and Gene Expert Ultra were both negative, and a bronchoscopy was done. There was no features of any endobronchial lesions, whereas the secretions which were there were a BAL was taken. BAL Gene Expert Ultra was negative. A BAL TB MJIT was sent, and the 6 weeks report was also negative. Although BAL grew a Pseudomonas aeruginosa, which was significant colony count. So this was the important bronchoscopic finding in this at this point of time in this child.
Any other workup for immunodeficiency or?
At this point of time, it was still, the child they were planning to follow up the child. The child was treated for Pseudomonas aeruginosa and called back for follow up, but there was a loss to follow up. Given the family situation, the parents did not follow back after 2 to 3 weeks. So only Pseudomonas was treated with levoflox, and following that, the parents failed to review back for the next 3 years. That is, now they presented back. So only thing, sweat test was done prior to, because CT was not reported to have any fistulous communication at that point of time, and neither did bronchoscopy find if even if there was, it could not be picked up that easily. And sweat test was done to considering this finding, and that was also negative, and it was a COVID pandemic, so that COVID was also done, and that was negative. So this child was treated with sensitive antibiotics for 2 weeks. They did not follow up, and following this current presentation for the past 3 years, child was at home having a difficult family situation, and currently presented with like I presented earlier, fever, cough, and cold, again with slight increase in respiratory activity, but admitted again just in wards. Vitally otherwise stable. Saturation was 97% at room air, so vitally stable. Anthropometry, as we can see, height was 140 centimeters, well preserved. Weight was 25 kgs, slightly, 25th to 50th centile. His BMI, his BMI was on the lower side, which was 3rd to 5th centile. But his physical examination revealed a clubbing of grade 2. So it was almost the angle was it was more obtuse, as we can see. I think it's quite evident on the thumb. So coming to respiratory examination, it was inspection was normal, palpation. There was normal expansion and tactile vocal phragmitis and percussion. There was a resonant note present bilaterally. Only auscultation, they revealed a reduced air entry noted in the left inframammary area, and there were coarse crepitations which were heard. So just a comparison, I have already shown the X-ray on the left side, which was in June 2022, and this was currently the X-ray done in 2025. And there was a significant increase in the pathological changes in the left lower zone, and there was which showed a worsening of the pre-existing disease, which was noted. So again, the child for the past 3 years was not admitted anywhere else. He just complained of cough, productive cough, but he continued to go to school, and there was no other major complaints as per the child. And he has gained weight gain was also noted. There was no failure to gain weight as such, but
Sonal ma'am, would you like to add anything to that X-ray?
Just there's been significant left lung volume loss now. You can see the mediastinum and trachea all kind of shifted towards the left side. And there is consolidation in the left lower lobe, which is still outing the diaphragmatic border. So definitely there is some active infection that is still going on. A lot of lung nodules and continued peribronchial thickening and these dilated cystic spaces that are all probably the bronchiectasis underlying it.
Thank you, ma'am. Vishal, continue.
The CT, should I sharing?
I'll share it.
Yeah,
Yes,
I'll just
request Vishal to stop sharing, and ma'am, please share.
Yeah, you can see my screen, right?
Yes, ma'am.
Okay, so this is the CT done now recently on 31st of July, and this is the mediastinal window. So these are the contrast enhanced images. Now, like we saw in the previous scan, right next to the trachea on the left side, you can see another dilated tubular air-filled structure, which is the esophagus. You can see on many sections, it's almost as big as the trachea. And as we go down, now here, you can see this, it becomes linear. And if you keep following it, you can clearly see it goes and it opens into the left mainstem bronchus just after the bifurcation of the carina. Okay, as we go further down, I would also like to highlight all these enlarged lymph nodes. So this is an enlarged pretracheal lymph node. You can see enlarged prevascular lymph nodes, precarinal lymph node also, which is fairly large, right hilar, left hilar, subcarinal, and all these lymph nodes are showing heterogeneous enhancement here in the aortopulmonary window. Okay, so a lot of large heterogeneously enhancing lymph nodes. And just to show this in the sagittal view,
But
where
so
you'll be able...
there was no central necrosis in any of those lymph nodes, right?
Ma'am, they're heterogeneously enhancing, so they could be partially necrotic for sure.
But in an infection, also you can get these lymph nodes that it may not be TB, right? With so much of infection sitting there.
Yeah, of course.
Yeah.
Of course, any infection which will cause heterogeneously enhancing lymph nodes. But here, this is the section I wanted to show you all. So on the sagittal, you can see the esophagus. And here you can see this diverticular outpouching. And then if you continue it down, it opens into the bronchus. Okay, so you can clearly see the tracheobronchial fistula formation over here. Okay, now I'll just move on to the lung window. Yeah, so this is the lung window of the same child. Now, again, as we come, now you can see that esophagus, which was appearing lucent, you can now actually see some material within it. So you know that there is aspiration happening. All of these air bubbles and this sort of liquid material within the esophagus. But now let's leave that for a second and focus on the lung windows. Here itself in the right upper lobe, you can see significant peribronchial thickening.
Dr. Sonal, it's not
Ma'am,
moving.
it's not moving, ma'am. It's hung at the mediastinal sagittal.
Oh, okay. One second. Let me start. Now?
Yeah.
Yeah.
Yes.
Okay. So here now you can see the trachea and you can see this esophageal lumen, which actually has like some sort of muck, some sort of liquid material in it. Okay, and as we come down to the lung sections here, you can see there are a lot of tiny nodules in the right upper lobe. You can see this polo type of sign, which is the thickening of the bronchial walls. Okay, there's almost like a pan-bronchiolitis. You'll see everywhere, all the bronchioles are showing wall thickening. There are some ground glass opacities. There are nodules in both lungs. This is the right middle lobe also, which is showing lung nodules. And as we move to the left lung, you can clearly see that there is extensive bronchiolitis, peribronchial wall thickening, nodules. And as you come down to the left lower lobe, you can see these dilated bronchioles, some amount of almost like a varicoid bronchiectasis. You can see these irregularly dilated cystic and saccular structures. And posteriorly along the subpleural margin, you can see these nodules with fuzzy margins and this peripheral halo of ground glass density. So all this is very much suggestive of some active infection going on. A lot of these nodules show that typical tree bud branching pattern, which of course is not synonymous with TB, but anything that causes peribronchial spread of infection. Like you said, he has Pseudomonas aeruginosa, that could also very well cause it. Okay. And as we go down, you can see the entire left lung, which is just completely studded with these nodules. And there is some amount of interlobular septal thickening also, which suggests there is very chronic infection going on. You can see all these clusters of subpleural nodules. So it's very likely that there is some primary infection and there's likely a superimposed secondary infection also. So yeah, that is all the findings. And if you could focus on this middle mediastinum part of the, you can definitely see that there is some aspiration going on in the esophagus. And you can see this fistulous communication here with the left main stem bronchus.
Here the esophagus doesn't appear to be that dilated.
Yeah.
In the upper sections, it does. Here. So it's all a function of the air passage between the two structures. I'm sure at some points during inhalation, you might see it more, or during exhalation, it might be less. So it'll be a dynamic process as well. But yeah, so definitely not a happy picture. A lot of infection, acute on chronic, with this fistula.
Thank you, ma'am. Should we proceed? What is the clinical bronchoscopy findings this time?
Yes, yes. So following this, we had done a bronchoscopy this time at the carina. The video is visible, right?
Yeah.
So entering the left main bronchus. So I mean, this was so initially given the radiological findings, we are expecting a lot of secretions. So this is not the first entry into the left main bronchus. A lot of secretions were suctioned out, and this was after clearing as many secretions as we could. This video was taken. So there is no visible fistulous communication in the left main bronchus up till the bifurcation into the left upper and left lower lobe bronchus. And at the same time, we had inserted a Rayleigh tube into the child's abdomen, and we gradually injecting the methylene blue dye. We were trying to establish that fistulous communication. So again, this is after suctioning out all the secretions which were there on the left side. So I think gradually at one point we can see bubbling in the left side. I think if it is not visible, this one.
Yeah.
So again, so this again, reaffirmed that there could be a fistulous communication. And to confirm, again, as we could not visualize the fistulous opening via bronchoscopy, in the same setting, we did an esophagoscopy. And as we can see, the esophagoscopy via rigid bronchoscope, in the mid esophagus, there was a small outpouching, which looked more like a diverticulum kind of a thing, but ureteric catheter was inserted just to see up till what distance it was patent. Again, not probe too ahead because again, didn't want to iatrogenically cause anything, but
It was going significant amount inside, so somewhere,
quite,
so probably it was again a fistulous opening only.
yes.
And you can see that purulent secretions coming from the bronchi also inside. This is the esophagus basically.
Yeah, so this mucosa looking healthy.
No, not really. The secretions, mucosa is looking okay, but the secretions coming out are purulent now.
Purulent, yeah.
So from this esophagoscopy, because the catheter was entering to one distance, it could be, it could be confirmed that it could have been a fistulous opening. But again, correlating the bronchoscopic finding with the radiological finding again gave the answer to this.
Sure.
So,
Would you want to quickly review literature because
Yes.
short of
So I
time?
think
Just
this
one
again,
question
this
in the chat box. In the CT, with this time, is hepatosplenomegaly still there? And clinically, was there
So
any?
there is some borderline splenomegaly. I cannot comment on the liver because the
clinically, yeah, nothing. The
entire picture is not there. Yeah.
clinically, the child didn't have any hepatosplenomegaly, and otherwise, like I mentioned, only the significant findings were in one area. I mean, mainly on auscultation in respiratory system examination. So, just one thing I just wanted to display was this coronal cut, and this again, I think ma'am would have. Again, this again just shows the fistulous opening. Yeah, I think.
Yeah.
Yeah, I can see it nicely. Okay.
So, okay. So So we got the pediatric surgery team involved, and we got a barium swallow done. Again, this was because the intervention of this child was again planned based on multiple factors, given the chronic lung
Can you see
disease.
the dye going into the lung?
Yeah.
Size
Yeah,
and
you can
It's like nicely, what do you see, this
demonstrate it. And
long,
even on this, you can see that the esophagus is dilated.
yeah.
So the dye is entering the lung around the sixth to seventh the rib, and that around corresponds to the around the left main bronchus, I think.
Correct. And it's only selectively going, radium is going
Usually
on
to
the left
the
side.
superior, and again, this usually corresponds to the superior segment. So, and most of the lung changes were also, I mean, wherever the dye is going, given that's basically where the aspiration is happening, and that's where the chronic lung disease, that bronchiectatic changes were also predominantly there. So,
Correct.
so following this, again, this child was just discharged recently, hardly 2 weeks, 3 weeks back, and again, BAL gene expert ultra was negative, whereas this time BAL culture sensitivity grew MRSA, and child was treated in the hospital for MRSA and then discharged with oral antibiotics. The planned for now following a treatment with completion of antibiotic therapy is going. We have planned to do a thoracotomy with fistula ligation and division of the two tubes and the two tubes with primary repair of the fistula. So just to cover some literature, bronchoesophageal fistula is a rare abnormal communication between the bronchial tree and the esophagus, leading to aspiration, in turn recurrent pneumonia and feeding difficulties. Unlike congenital deaf, bronchoesophageal fistula is typically acquired in older children and very frequently under-recognized. So causes, though TB is by and large the predominant cause in acquired bronchoesophageal fistula, especially in high TB areas with such a significant family history. And even though it is the most common cause, it is not the only cause. There can be other causes, including congenital causes, very unlikely though, given the clinical scenario of this child. Second is non-TB infections, like we've seen in this child, which again could still be true, which is Pseudomonas, which is around 10 to 15% of the total number of cases, and it is causing necrotizing pneumonia with abscess, which neither was there in this child as such. But other than this, fungal infections, iatrogenic causes like foreign body and instrumentation during esophagoscopy, and less likely in pediatric age group is neoplastic, though it's a quite more common cause in adults. So symptoms, very classical symptom, though we initially prior admission, I think the child was asked this admission, again, child was initially asked cough after eating food. Initially, it was not the grandmother who was there, again said there was no significant as such history, but there was other, again, common symptoms, a recurrent lower pneumonia, feeding intolerance, failure to thrive, chronic cough, and poor response to antibiotics. And diagnostic tools like you've seen, barium esophagogram, which is the best for fistula visualization, CT chest, and bronchoscopy and endoscopy are both mainly diagnostic and therapeutic if in certain situations, but not in this child as such. So coming to the therapeutic procedures which can be done, there are three main things. One is the fibrin glue insertion. This is usually done in smaller fistulas, less than 5 millimeters, more if they are benign, like especially congenital and post-infective, where there is no airway compromise, and especially following a failed conservative management. Mainly, it's also seen in TB, where TB treatment fails and there's a persistent leak, and it can be used with, in addition, it can be used with ablation or electrocautery. This is safe as a first line, but not a definitive treatment. So second, again, another option is endoscopic stenting, which is used in slightly bigger fistulas. And this is mainly airway stenting or esophageal stenting. And evidence of, if there is evidence of any type of airway compromise in the, meaning that there is either bronchial narrowing or there is collapse or obstruction of the bronchi, then we do a endoscopic stenting, which is preferred. Again, this is another alternative to those who are poor surgical candidates, that is, who are extremely morbid, those children who cannot be operated on, then they go ahead, usually endoscopic stenting is preferred. And this use an airway stent first if bronchial narrowing is there, and if both the airway and the esophagus are compromised, then a dual stenting is done. Whereas the definitive treatment is always going to be surgical repair. Like I said, there's repair of the fistula. You divide the two tubes, and then layering of the two tubes separately, suturing of the two tubes separately. And this is indication for a surgical repair is persistent fistula, that is, or a larger fistula and a more complex fistula, especially in fistula associated with TB, lymphadenitis, or any lymph node eroding and causing a fistula, and recurrent fistula post failure of the other lines of treatment, that is glue or stenting. And these are the surgical, I mean, all the interventions which have been mentioned in the literature, mainly very uncommon in pediatric age group. A lot of the literature is found in the adult pulmo journals. So one thing I would like to add is that though initially history was refuted, but again, after probing, after doing all these interventions, uh, after asking, this video was taken after all the interventions were done, and when we actually found that there was a bronchoesophageal fistula. So we can see this Ono sign where you have typical coughing after having fluids. So this is classical paroxysmal coughing, especially after having liquids, is seen in this type of fistula. And yeah.
So what is the plan for him?
His plan for
And
surgical
surgery,
intervention.
thoracotomy with ligation of the fistula is going to be planned, but currently he's receiving antibiotics for MRSA.
Immunodeficiency workup was done.
No.
No, ma'am. Not.
Oh, there are no other pointers, but I would still feel that should be done to complete the list of investigation. Tanvi, can you quickly take the questions from the chat box?
Yes, ma'am. Just coming to that, most of them have been answered. So Saurav Chen sir has said one that esophageal TB is notorious to cause erosions and secondary bronchoesophageal communications. So that was remained our highest probability. Dr. Khushbu has asked about a technical difficulty in suctioning out with the scope and the impaired vision. I think
I mean, there's no as such technical difficulty, but in any other bronchiectasis, you get a lot of thick viscid secretions, and there it takes some time to suction them out. And only after suctioning out, if there is any type of fistulous opening or anything you want to
You can
visualize.
see the bronchi were clearly visible, right?
yes.
Yeah.
So definitely there is no what do you say difficulty in suctioning them. It takes time, but it eventually comes out. The reason why we used a portable scope in this child, because we always had that back, thought in our mind whether this is TB, whether this is TB, whether we should use a disposable bronchoscope or whether we should do a regular Olympus bronchoscope. So here in this child, we used a disposable one because that MDR thing is always there in our mind.
Right. Thank you, sir. And yes, the Pulmo-Radio Crosstalk videos are available on the IP Mumbai channel of YouTube.
That you answer it, okay.
Everything else has been answered. Water soluble contrast of barium. Barium is used for suspected aspiration.
Yes.
And the main question is, yes, if we attribute it to TB, then how come the child was okay for 3 years without any worsening? So I think that has been answered
Maybe-
because
And if
the
it is
lingering.
TB, a good percentage of TB can actually even treat itself without, that's well known. Spontaneous resolution can occur in tuberculosis. And I think it also depends on the child's immunity here. The child looks reasonably well grown, despite the fact that he has such a big fistula, which is causing him chronic infection in the lung. Having said that, we have not proved TB.
Yes.
And then
I think
further,
maybe when you do a surgical intervention, maybe you should take a biopsy specimen and look at histopathology. So maybe at that point of time, we should still not rule it out to rule it out completely. I think we should do a histopathology at that point of time.
so any plan for ATT based on the available evidence?
Not at present. Twice bronchoscopy done, and both the times it was negative for tuberculosis. So at present, we are not planning for any. If this child had a history of strong contact with the MDR tuberculosis, and
Right.
this child when was presented the first time in 2022, history was only 5 days. And because there was a history of tuberculosis contact, we extensively investigated at that point of time as well. But in a child with having a history of 5 days to extensively investigate just based on uh, uh, Cox contact or radiological findings is too difficult to this. And in between also the child was normal, relatively normal for 3 years. Imagine a child being normal for 3 years, not requiring hospitalization. Not in fact there is a component of also being a single mother also because she was working and the child was going to the what do you say this he was going to some neighbor's place during the daytime. Mother used to come at night and look at the child, so that component also was there. So probably, but the child was relatively well grown in the end as well. At the end of 3 years of whatever duration, the child has not followed with us.
Possible.
So I would say this is definitely a fistulous communication, acquired versus congenital. That doubt will always remain in your mind. What is there in the favor of congenital is the child probably did not deteriorate not being on AKT. If we are seeing that this is tuberculosis, not deteriorating despite not receiving AKT. Definitely, there can be a self-healing, I understand, but forming a fistulous communication, I would suggest that the child should have received AKT and not receiving AKT despite being a fistulous communication. In a child with tuberculosis, less likely that this is tuberculosis. Okay, then more likely to be a congenital. Now, what is not in favor of congenital is the child is normal till 5 years. Okay, and not having any symptoms till 5 years. The symptoms started after 5 years. There are reports of adults being presented with, fistulous communication in adult to adolescent or adults as well. But the symptoms has to be there in between. The symptoms are not there till 5 years. They will be definitely symptomatic. The presentation, the diagnosis may be late, but the symptoms should start initially, in a congenital. That's what I feel.
It could have been missed as just a regular sardi khasi treated with thoda, like those kind of symptoms.
First 5 years, nothing.
Nothing.
There's no.
Yeah, last 3 years, definitely.
Okay. So then one iatrogenic cause, could it be because of forced Riles tube insertion?
The
But
child, during which admission? During the Riles tube admission insertion during which
No,
admission?
it's come as a general question
No,
that
it
whether
doesn't. No. Usually,
only time I've seen a Riles tube insertion go wrong is I've seen it in a neonate when a Riles tube had perforated the stomach. Okay. And we had a pneumoperitoneum. But that also self-heals because the kind of injury that you will do with a Riles tube insertion going wrong will self-heal. It will not lead to such a fistulous communication which will go on for so long. The one more thought that I want to definitely leave with the fellows and the residents who are there, when any time you have such a problem, such a kind of bronchiectasis which was there, even on the first CT, airway clearances are very, very important. So that thing and management should not be forgotten because that will be on, and even the duration of antibiotics should be much longer when you have gram-negative, when you have such a bronchiectasis. And at the drop of a hat, one should start antibiotics. So that is for managing any suppurative lung disease. Thank you so much. I think it was a wonderful.
We have one last question. Do we have time to take it, ma'am? The experience about methylene blue versus iodine.
Quercetin iodine is ideal. Should avoid methylene blue. Okay, especially for bronchoscopies.
Yes. Thank you so much. And me, please conclude.
Thank you so much.
Thank you, guys. Thank you, radiology team.
Thank you, Vishal. Thank you, Sonal ma'am, Hiren sir, Indu ma'am, for another wonderful talk where we learned so much new. And hopefully we'll be one step further in suspecting this if we ever come across such a case. So,
thank you.
Thank you, everyone.
Good evening. And the Vadia team, please let us know if you find some further on your.
Yes.
Please let us know if you get any additional clues about the etiology, and the follow-up about the management.
Sure.
And keep sharing such interesting cases. We thoroughly enjoyed seeing the radiology images of this child.
So what I felt, no, here it was radiologist domain more than a pulmonology domain, and we were really thrilled to share this case because we thought there will be lots of discussion on this case and there will be lots of inputs from radiology, and it will be like a thrilling experience for all of us.
Yes, that we have been thrilled for the last 7 sessions, Parmarth. We have had so much thrill that we are so delighted to continue.
It was going, madam. That's why we changed the time.
Yes. Okay.
Okay.
Thank you.
Okay,
Thank you
thank
so
you.
much
Bye,
again,
everyone.
everyone.
Good
Thank
night.
you, ma'am.
Bye.
Thank you, sir.
Guys,
Bye. Good night.